Hi everyone, my name is Magdy Abdel-Hamid, Professor of Cardiovascular Medicine at Cairo University. My topic of presentation today is a very challenging subject, a life-threatening condition, which is acute heart failure. So how to manage patients with acute heart failure? This slide summarizes the classification of patients who present to the ER with symptoms and signs suggestive of acute heart failure. We know the classification of heart failure according to the ACC, AHA, different stages. Stage C, patients who have structural heart disease with current symptoms of heart failure. Stage D, patients who have refractory heart failure. And stage B, patients who have structural heart disease but without symptoms or signs of heart failure. And stage A, patients who are at high risk for heart failure but without structural heart disease or symptoms of heart failure, like patients who have hypertension, diabetes, obesity, dyslipidemia. So patients presenting with acute heart failure, 75% of those patients have worsening of chronic heart failure, so acute decompensated heart failure. 5% of patients have an advanced heart failure in stage D, refractory heart failure, so 5% of patients have an advanced heart failure. And 20% of patients have an acute de novo heart failure. And this interesting paper, which was recently published in the European Heart Journal this year, for acute cardiac care and the use of inotropes in acute heart failure patients. And we can see that acute heart failure carry a poor prognosis because acute heart failure is associated with an in-hospital mortality of 5% and 3-month mortality of 10%. And according to the European Society of Cardiology heart failure long-term registry data, the 1-year mortality or rehospitalization rate of 36%. So acute heart failure is a life-threatening disease. The in-hospital mortality, according to this slide, is around 3.8%. And within 30 days, which are the vulnerable phase for patients with acute heart failure, the mortality rate is around 10%. And after 1 year, the mortality increased to be more and more, which reach up to 20%. And up to 5 years, the mortality for patients with acute heart failure is around 40%. Every patient presenting to the ER with symptoms and signs suggestive of acute heart failure should be examined properly to identify symptoms and signs of congestion and to identify the perfusion status of vital organs. So congestion can be indicated by pulmonary congestion, the presence of dyspnea or apnea, paroxysmal nocturnal dyspnea, high venous pressure, peripheral lower limb edema, congested liver, as well as positive abdominal compression test. And signs of hypoperfusion means cold sweated extremities, low renal perfusion leading to oliguria, cerebral hypoperfusion leading to mental confusion and obtundation, dizziness, and narrow pulse pressure. So we might have one or more of these combinations of congestion and hypoperfusion. The patient who is compensated, he is warm and dry, so he has no signs of congestion, as well as he is well perfused. While the most common type, patient who is wet, patient who is congested, and he is well perfused. So this is warm and wet patients. And we might have a patient who is cold and dry, signs of hypoperfusion, and he is dry, is not congested. And the most complex form in patients with acute heart failure, patients who have both congestion as well as hypoperfusion. This is the cold and wet type of patients. So every patient with acute heart failure on presentation, the following measurements should be done. We have to estimate the natriuretic peptide levels, PNP, anti-proBNP level, or mid-region pro-atrial natriuretic peptide in all patients presenting with acute shortness of breath and suspected to have acute heart failure, because this can differentiate dyspnea due to acute heart failure from dyspnea due to other causes. And this recommendation is class 1A recommendation, as well as all patients will be subjected to 12-lead electrocardiogram, which can identify whether the patient has sinus rhythm or atrial fibrillation, recent acute MI, other abnormal criteria. Chest X-ray is important to reveal signs of pulmonary congestion and to detect other cardiac or non-cardiac disease that may cause or contribute to patient symptoms, as will add other biomarkers like cardiac troponin, kidney function, electrolytes, blood sugar, complete plaque count, liver function tests, as well as TSH, which is class 1C recommendation, and the echocardiography is mandatory, class 1C, recommended immediately in hemodynamically unstable acute heart failure patients and within 48 hours when cardiac structure and function are either not known or might have changed since previous studies. What are the criteria for admitting those patients to the ICU or CCU? Patients who are in need for intubation or mechanical ventilation, patients who have signs and symptoms of hypoperfusion, patients who have an oxygen saturation less than 90% despite supplemental oxygen, patients who are using accessory muscles for breathing, respiratory distress with estimated respiratory rate more than 25 per minute, and the patients who have bradycardia with heart rate less than 40 or a heart rate more than 130 beats per minute, systolic blood pressure less than 90 millimeter mercury. So what are the goals of treatment in patients presenting with acute heart failure? The immediate goals for treatment is to improve hemodynamics as well as organ perfusion, and to restore oxygenation, to relieve symptoms, to limit cardiac and renal damage, which is common in those patients, as well as to prevent thromboembolism and minimize the length of hospitalization. At the intermediate stage, we have to identify the etiology of acute heart failure and to identify comorbidities and precipitating factors for acute heart failure, and then to titrate therapy to control symptoms and congestion and optimize blood pressure, and initiate and up-titrate the life-saving drugs which improve survival and decrease hospitalization. And before discharge, the long-term plan for patients with acute heart failure should be discussed in details regarding the care for patients, the schedule for up-titration and the monitoring of pharmacological treatment, the need and timing for review for device therapy if it's indicated in those patients, and who will see the patient for follow-up. Then the patient should be included in disease management program, patient education, initiate appropriate lifestyle adjustments, prevent early readmission, which is common after discharge, 25% within the last 30 days after hospital discharge, and finally to improve symptoms, quality of life and survival, which is the goals of treatment in patients with also chronic heart failure. This is an interesting algorithm according to the ESC heart failure guidelines, European guidelines 2016. We can see that patients presenting with acute heart failure and after identification of the volume status and the hemodynamic status, 95% of patients are wet who have an acute decompensated heart failure characterized by pulmonary congestion and adequate peripheral hyperfusion. The wet and warm patients, we have a vascular type which is characterized by fluid redistribution and high blood pressure. So those patients need vasodilators and diuretics. And the cardiac type fluid accumulation, which is characterized by congestion with normal blood pressure. So diuretics, vasodilators, ultrafiltration if needed are recommended. If we have patients who have signs of hypoperfusion, then patients need an inotropic agents to increase blood pressure above 90 millimeter mercury, and to consider vasopressors in refractory cases, diuretics when perfusion is corrected, and to consider mechanical circulatory support if it is indicated. In patients who have blood pressure more than 90, vasodilators, diuretics, and to consider inotropic agents in refractory cases. And it's very important in patients who have blood pressure is to rule out hypovolemia. So fluid challenge is important to rule out patients who have hypovolemia due to aggressive use of diuretics, which could be an important cause for low blood pressure and can be corrected by fluids. So this is the recommendation according to the guidelines, again, for oxygen therapy and ventilatory support, that monitoring arterial oxygen saturation is recommended, it's class 1C, and doing black gases is very important, which is class 2A recommendation. Oxygen therapy is recommended in patients with acute heart failure and oxygen saturation less than 90%, and PO2 less than 60 millimeter mercury to correct hypoxemia. It's class 1C recommendation. A non-invasive positive pressure ventilation like CPAP or BiPAP should be considered in patients with respiratory distress, a respiratory rate more than 25, oxygen saturation less than 90%, and started as soon as possible to decrease respiratory distress and the need for mechanical ventilation. Non-invasive positive pressure ventilation should be used very cautiously in patients who have low blood pressure, because this could lead to hypotension, and blood pressure should be monitored regularly when this treatment is used. Intubation, mechanical ventilation is recommended if respiratory failure leading to hypoxemia, PO2 less than 60 millimeter mercury, high PCO2 more than 50 millimeter mercury, and acidosis pH less than 7.3, which is class 1C recommendation. Again, diuretics represent a cornerstone for treatment to have evidence of pulmonary congestion and are adequately perfused. So loop diuretics is the rationale to be considered when using loop diuretics that induce decongestion, pulmonary and peripheral, and lead to fluid removal. But we have to take in consideration that the use of diuretics could lead to worsening of renal function. A rise of serum creatinine is expected with aggressive diuresis, and the cardiorenal syndrome is defined as serum creatinine increase more than 0.3 milligram per deciliter with the use of diuretics. Diuretics also can lead to electrolyte deficits, hypokalemia, and hyponatremia, hypomagnesemia, which can precipitate serious ventricular arrhythmias. Diuretics also can lead to hypovolemia, and diuretics sometimes in the literature have been associated with increased risk of mortality. So we have to keep eyes on electrolytes and creatinine with the use of different doses of diuretics. This slide summarizes how to use diuretics in treatment of acute heart failure patients, and its class 1C recommendation. And in patients with new onset acute heart failure, or those with chronic decompensated heart failure not receiving oral diuretics, the initial recommended dose is 20 to 40 milligram intravenous furosemide. For patients who on chronic diuretic therapy, initial IV dose should be at least equivalent to the oral dose, which is class 1B recommendation. To give diuretics intermittent policies or continuous intravenous infusion, the dose and duration should be adjusted according to patient symptoms and clinical status, which is class 1B recommendation. And in patients who have resistance to diuretic, combination of loop diuretic with thiazide-like diuretic like metolazone or spironolactone may be considered in patients with resistant edema or insufficient symptomatic response. And this is class 2B recommendation. Use of diuretics in patients with acute heart failure, intermittent bolus versus continuous intravenous infusion. was studied in a very important study, which is this trial published in the New England Journal of Medicine in 2011. And we can see in this slide, interestingly, that the use of continuous versus intermittent bolus, low versus high dose, was not statistically significant in terms of the primary endpoint of mortality, which was a composite endpoint of death or rehospitalization or emergency department visit. So there is no difference in the outcome between both different doses and method of use of diuretics in patients with acute heart failure. What about intravenous vasodilators? The intravenous vasodilators improve cardiac function by reducing both preload and afterload and increasing stroke volume, and it may be useful in patients who have a high blood pressure. However, we should know that vasodilators can lead to some side effects like headache, hypotension, tachyphylaxis with prolonged use of vasodilators, and should be avoided in patients who have an obstructive lesions like tight mitral stenosis, aortic stenosis, avoided in patients who have low blood pressure and no evidence of sustained symptom relief. So the guidelines recommended intravenous vasodilators as class 2A recommendation for symptomatic patients with acute heart failure who have a systolic blood pressure more than 90 millimeter mercury and without symptomatic hypotension. And symptoms and blood pressure should be monitored frequently during administration of intravenous vasodilators. In patients with hypertensive acute heart failure, intravenous vasodilators should be considered as initial therapy to improve symptoms and reduce congestion. This is also class 2A recommendation. Inotropes are recommended in patients who have signs of hypoperfusion because inotropes improve blood pressure, increase cardiac output to maintain perfusion, and preserve end organ performance in patients with severe reduction in cardiac output. It improves renal blood flow, and diuresis, of course, will improve after increasing renal blood flow. The consideration for the use of inotropes in patients with heart failure: it accelerates heart rate. It can precipitate serious ventricular arrhythmias. It increases heart rate, so it increases myocardial oxygen consumption, so accelerating myocardial ischemia. And there is a concern for increasing mortality with the use of different inotropic agents. So this is an interesting slide for practical consideration guiding the use and selection of inotropes in acute heart failure. Do we really need an inotropes in patients with decompensated heart failure? We have to identify signs of hypoperfusion because low cardiac output criteria is an indication to use an inotropes. And we have to assess the volume status because adequate intravascular volume should be established by the presence of normal central venous pressure, the negative fluid challenge response, to rule out hypovolemia as a cause of hypotension. And we have to look for treatable causes leading to low cardiac output and hypotension, like acute myocardial infarction, pulmonary embolism, tachyarrhythmias, bradyarrhythmias, and tamponade or valvular heart disease. And then lack of viable alternatives like PCI or CABG, or the need for mechanical circulatory support. So what is the best inotrope to be used in patients with acute heart failure? In patients who are already on chronic beta blocker therapy, levosimendan or milrinone are considered the drugs of choices because we cannot use beta agonists like dobutamine. Patients with cardiogenic shock, norepinephrine plus dobutamine or levosimendan. Patients who have right ventricular failure and pulmonary hypertension, levosimendan or milrinone. In patients with worsening renal function in cardiorenal syndrome, levosimendan is recommended. Ischemic heart disease, levosimendan or dobutamine. Septic cardiomyopathy, norepinephrine plus dobutamine or levosimendan. Severe takotsubo, levosimendan is the inotrope of choice. And when to wean your patients from inotropes? Different criteria should be identified, which means stabilization criteria, which are improvement of symptoms, improvement of vital signs, systolic blood pressure, heart rate, oxygen saturation, improvement of invasive parameters, cardiac index and wedge pressure, reduction in serum lactate below 2, and good diuresis, and improvement of echo Doppler indices. So again, the guidelines recommended short-term infusion of inotropic agents in patients who have blood pressure less than 90 millimeter mercury, and this is a class 2B recommendation. An intravenous infusion of levosimendan or phosphodiesterase enzyme 3 inhibitor may be considered to reverse the effect of beta blockade in patients already on beta blocker, and this is a class 2B recommendation. Inotropic agents are not recommended unless the patient is symptomatically hypotensive or hypoperfused because of safety concern, and this is class 3 recommendations. Vasopressors like norepinephrine may be considered in patients who have cardiogenic shock despite treatment with another inotrope or to increase blood pressure in the vital organ perfusion, and this is class 2B recommendation. And it's recommended to monitor electrocardiogram, blood pressure when using inotropic agents and the vasopressors, as they can cause serious ventricular arrhythmias, myocardial ischemia, and in the case of levosimendan and the phosphodiesterase enzyme inhibitors can induce hypotension. And this is class 1C recommendation. In such cases, an intra-arterial blood pressure monitoring should be considered a class 2B recommendation. In patients with acute heart failure, thromboembolism prophylaxis also is recommended with the use of low molecular weight heparin in patients not already anticoagulated and with no contraindication to anticoagulation to reduce the risk of DVT and pulmonary embolism. This is class 1B recommendation. Other drugs, which is class 2A, digoxin and or beta blocker as first-line therapy to control the ventricular rate in patients with atrial fibrillation. Amiodarone therapy may be considered a class 2B recommendation also. Opiates may be considered to relieve dyspnea and anxiety in patients with severe dyspnea, and this is a class 2B recommendation. And in renal replacement therapy is considered also in patients with acute heart failure. Ultrafiltration may be considered for patients with refractory congestion who fail to respond to diuretic therapy, class 2B recommendation. And renal replacement therapy should be considered in patients with refractory volume overload and acute kidney injury. This is class 2A recommendation. The criteria which should be considered for ultrafiltration: oliguria unresponsive to fluid resuscitation, severe hyperkalemia, severe acidemia, serum urea level more than 150 milligram per deciliter, and serum creatinine more than 3.4 milligram per deciliter. These are the criteria for renal replacement therapy in patients with acute heart failure. What about device therapy or mechanical circulatory support, which is considered also a therapeutic option in patients with acute heart failure? Bridge to decision and bridge to bridge in patients, the use of short-term mechanical circulatory support like ECMO or extracorporeal life support in patients with cardiogenic shock until hemodynamics and end organ perfusion are stabilized. Bridge to candidacy, the use of MCS, LVAD, left ventricular assist devices to improve end organ function in order to make the ineligible patients eligible for heart transplantation. Bridge to transplantation, the use of LVAD or BiVAD to keep patient alive who is otherwise at high risk of death before transplantation. Bridge to recovery, the use of MCS, LVAD to keep the patients alive until cardiac function recover to remove the mechanical circulatory support. And finally, destination therapy is also an indication for patients, long-term use of MCS LVAD as an alternative to transplantation in patients with end-stage heart failure, ineligible for transplantation, or long-term waiting for heart transplantation. What are the patient's criteria which are considered the eligibility criteria for LVAD? Patients with more than 2 months of severe symptoms despite optimal medical and device therapy and have more than one of the following: ejection fraction less than 25%, peak VO2 less than 12 milli per kg per minute, repeated hospitalization, dependent on inotropes, progressive end organ dysfunction, and the absence of severe right ventricular dysfunction. What are the criteria which should be considered when evaluating any new therapeutic option for patients with acute heart failure? This is an interesting paper which showed that the current and future management of acute heart failure symptoms, the ideal drug for acute heart failure should improve signs and symptoms, should improve hemodynamics without adversely affecting heart rate and blood pressure, should improve the neurohormonal status, don't cause myocardial or kidney damage, should be effective in the context of current evidence-based therapies such as ACE and beta blockers, should have an efficacy to be used in both acute and chronic setting, and should be affordable, and very important, this new drug should reduce both in-hospital as well as post-discharge morbidity and mortality. And this slide summarizes different trials used different inotropic and vasodilator agents for acute heart failure patients, but unfortunately they did not succeed in reducing the primary endpoint mortality or rehospitalization. And this is applied for optimal heart failure trial using milrinone and Veritas for endothelin receptor antagonist tiosin 10, Survive for levosimendan, Everest for tolvaptan, which is our gene vasopressin receptor antagonist, Ascend heart failure trial for nizretide, which is the recombinant form of BNP, or Protect trial using rolophilin, which is a vasodilator. And this slide also summarizes different clinical trials in acute heart failure, but unfortunately there was no clinical benefits in many of the studies, as have been seen in this slide, in relaxed acute heart failure for serelaxin and for true acute heart failure trial using olaritide. Finally, this is an interesting algorithm for initial management for patients presenting with acute heart failure. All patients should be examined properly, and we should rule out CHAMB. CHAMB means C for acute coronary syndrome, like acute STEMI, because those patients should be sent directly for the cath lab to undergo a primary PCI. Patients with hypertensive emergency, and A for arrhythmias, like patients who have rapid atrial fibrillation, patients who have ventricular tachycardia, so cardioversion is highly indicated, and patients who have mechanical acute complications like acute mitral regurgitations, who should be sent directly for surgery, and finally patients who have pulmonary embolism, which should be treated with thrombolysis. So we have to rule out these causes as etiologies for acute heart failure. We have to identify the respiratory failure present or not, because ventilatory support using oxygen, non-invasive pressure ventilation, CPAP, mechanical ventilation are recommended according to the indication. And the patients who have cardiogenic shock in the absence of the reversible causes, circulatory support is essential using pharmacological therapy or mechanical circulatory support devices. So at the end, we can say that acute heart failure is a life-threatening condition. Early diagnosis and proper management, starting from the ER until patients discharge, are critical for improving the symptoms, hemodynamics, and improving survival over the short term as well as the long term for patients. Thank you for your attention.